Good morning, everybody. On behalf of myself and my co-moderator, Dr. Milanese, welcome to this webinar. And today we will cover very, very important and topics that the times don't get from our neurosurgical community the type of attention that they deserve. We will hear about what are the practical implications of novel developments in artificial intelligence as they apply to neurosurgery. And then we'll cover another very important topic. It's about ergonomics, why the instruments are designed in a certain way and how to use based on their design. And we will also look at what is the place of simulation in neurosurgery. There's been a lot of advances and very, it has reached a point where it really has a very important role in the education of our future generations of neurosurgeons. I pass the stage now to my co-moderator, Dr. Milanese from Sao Paulo, Brazil. Vanessa, please.
Good morning, Dr. Lanzino. Good morning, everyone, Dr. Barn, Dr. Portolotti, Dr. Salazar, and all the audience here, neurosurgeons from all over the world. It's my great honor. Thank you for inviting me, Dr. Lanzino. It's my great honor to introduce Dr. Byrne, that is now the chairman at Mayo Clinic, Florida. He's the chairman of the Department of Neurological Surgery in Florida. And he has a great leadership role in numerous professional societies, including president of the Neurological Society of America, director of the American Board of Neurological Surgeons, board of directors of the American Association of Neurological Surgeons, board of directors of the Congress of Neurological Surgeons, and president-elect for Society of Neurological Surgeons. I had the honor to meet him in person in last May, and I'm really looking forward to his talk about artificial intelligence in neurosurgery. Thank you so much, Dr. Barn, for being here today with us.
Right. Thank you very much for the invitation. I'm pleased to be here. I'm going to share my screen here. You guys let me know if you're seeing what I'm seeing. You see my screen?
Yes, we see it very well.
Yes.
Very good. All right. I'll be talking about artificial intelligence and neurosurgery, and just that topic alone, I could talk for many hours. I'm just going to hit some of the highlights in these 30 minutes. There's so many different topics to talk about. This is such a powerful tool. I was literally reading this morning about the politics of chip making, and I don't know if anyone's ever heard of the company of ASML, but if you bought their stock about 15, 20 years ago, you'd be a billionaire. They are, it's the Advanced Semiconductor Materials Lithography Company, and they make the background of 2/3 of the AI chips being made right now. And it's such a powerful company. And the United States has sanctions against Italy and Norway because they're sharing some of this technology with China. I mean, the politics behind this is so intense because the power is so impressive. So you'll see there's so many different things you can talk about with AI. I'm just going to talk about neurosurgery and things that you guys might find interesting this morning. So I'll just give a brief introduction about AI. We'll talk about some current state usages, some of which we're rolling out here at Mayo, Florida. Mayo is really, really deeply invested in AI. We'll take a look at some of the neurosurgical AI literature and where it might be used in the future. So just getting to the basics, I'm fascinated by and obsessed with AI because I'm a math nerd at the very base of this. this is all just advanced math, and frankly, not that advanced. It just has a lot to do with iterative sequences and things like the Fibonacci sequence, where you see just repetitive patterns, and you can pick out these patterns in nature. You see it through nature all the time. And I love the math of nature. And by the way, that math of nature very much applies to the brain. The more we look at these patterns, we see patterns that are easily explainable with these iterative sequences in neuroscience. And it's just fascinating for anybody with a math background. And in reality, AI is really just math. It's not magic. It seems magical, but it's just math, and it's just Bayesian inference and Boolean algebra and linear algebra. In fact, this is one of my favorite quotes. The rebranding of linear algebra as artificial intelligence may be the most successful marketing campaign of all time. And that is true. Linear algebra is just a massive number crunching. It's mind-numbingly boring if you're doing it, but the computers can do it with ease and extreme accuracy. And that's where the power comes from. And in reality, mathematics is the language with which God has written the universe, as Galileo said. So you get a glimpse of how things work when you really delve into AI. And I'm not the only one interested and enthused about AI. If you take a look at some of the quotes here, artificial intelligence will have more profound impact on humanity than fire, electricity, and the internet. That is a bold statement, but it's an extraordinarily powerful tool. So when you think about it, and I say it's advanced math, it's advanced statistics. So what's the difference between AI and statistics? Your standard biostatistics. This is a really good paper from the New England Journal from last year. And really what it boils down to is that AI is particularly useful for massive data sets. So we've got 10 million patient charts like Mayo Clinic does. That's just too much for standard mathematical techniques to figure out what's going on in any sort of hidden patterns. AI is extremely good at this. The downside is it's an opaque process. It's very difficult to say, how did the AI figure out what it figured out? Therefore, it's difficult to reproduce, and it's very specific to that data set and may not be reproducible on other data sets. So it's particularly useful with huge data sets where you're looking for maybe small hidden patterns. It's very interesting with novel data sets without precedent. Of course, we don't always have novel data sets. And then ideally, you'd want to have external validation to combat the problem of the black box of what happened and how did the AI figure this out. So we just take a look at this. This is not a novel data set, but it's a massive data set. When you think about it, we're looking at EEGs. EEGs just look like giant muck of squiggly lines to the uninformed. But of course, there's tiny patterns underneath. It's a summation of many, many, many patterns, and nothing picks that apart quite like AI does. So an AI program put together was tested against a panel of expert epileptologists, and guess what? The AI is every bit as accurate as a panel of expert neurologists. Just came out in JAMA Neurology last year. When I talked to our head of epileptology when I was at Rush, this is a man who'd been doing epileptology for 35 years. I said, "What do you think of this?" He said, I think I'm really glad that I'm about to retire. So that's the power that AI has for these massive data sets. AI can do things like just taking a look at, this is all fundoscopy. So we're talking about tens of thousands or hundreds of thousands of fundoscopic pictures, can take a look at this. And, to you and I, we see the disc, the cup, we see the retina and so on. AI looks at this and can tell you how old the person is, whether they smoke, what their hemoglobin A1C is, what their blood pressure is. And for the first time in history, I mean, hundreds of thousands of ophthalmologists have looked at retinas. And for the first time in history, the AI figured out that just looking at a retina, you can tell a person's gender with 97% accuracy. So there's so many hidden patterns here and things that we would not pick up that AI picks up very naturally. This just came out of the Google DeepMind team. Google's DeepMind team is one of the most advanced AI programming teams in the world. These are the people who put together AlphaZero and AlphaGo, that put together the most powerful chess engines in the world. Well, they're now working on differential diagnosis for medicine, and they found that their large language model they put together was as accurate and in times more accurate than a panel of medical experts in doing differential diagnosis in really complex cases. So you see where all of this is going. This is something, if you're not interested in it, that's fine. If you think that this isn't going to affect you, you're wrong. So it's worth knowing all of this. I personally am fascinated. I can't look away from this, but I don't think anybody's going to be able to avoid it. Specific to neurosurgery, this just launched, I think it was a week and a half ago. This is Atlas GPT, Aaron Cohen-Goodall's product. By disclosure, I'm now on the board of Atlas GPT. Aaron just invited me for that. This is a large language model put together based on a 6 different layer model. So it increases the accuracy, decreases hallucinations, so the chance of it ever being wrong. When this model was tested against standard neurosurgical questions, question sets, it got 98% of the questions correct, and the ones it got wrong were probably just too vague for it to figure out. So this product just came out. It's remarkably easy to use. You can query it as a surgeon, you can query it as a medical student, query it as a layperson just trying to get answers about your condition. I found it to be remarkably easy to use and very, very accurate. So if you've got a really tough case and you want to get some advice on it, you can just put all the details of the case in. It'll think for half a minute, and then it'll give you from my experience, a very reasonable plan of attack for whatever the problem is. So this is just the first iteration of what we're seeing in neurosurgery. I do believe that this is going to be a part of what we do in the future. I do believe that these are going to be the second opinions that people can get from anywhere in the world when they have a complex problem. They can literally go to an engine like this and get a suggestion for a solution. And all literature-based, all based solely on the literature of neurosurgery. And that's based on relatively more primitive LLMs. The next LLMs coming out, ChatGPT 4.0 just came out. ChatGPT 5 is going to come out at the end of the year. God knows what 6, 7, and 8 are going to look like. And then there's all the other ones, Claude and so on, all the other LLMs that are coming out. It's amazing what's happening here. I mean, it's getting to the point where these LLMs are almost at artificial general intelligence. It's remarkable, and it's fun to watch. But besides fun to watch, it's very, very useful. Now, this paper came out last year out of the UCSF group, and just documenting that their on-call junior residents spent 9 hours of their shift using electronic health records. So it's all of this Epic fatigue and Cerner fatigue. It's amazing how much time our residents spend to interact with the EHR. But it's not just the residents, it's the nurses, it's the PAs, it's the attending neurosurgeons. We're all sort of, it's almost like we don't work for the medical institution anymore. We work for our Outlook calendar and for Epic. So there are ways to tame these beasts. There are ways to make this easier on us. And most of these are going to be AI solutions. A lot of this right now, I have to say, Mayo Clinic is deeply, deeply invested. It's part of the reason why I moved to Mayo Clinic as an AI enthusiast. At this point, Mayo Clinic is invested tens, if not hundreds of millions of dollars in AI solutions. They have contracts with Google and Microsoft. Mo Biden is really deeply into this with the neuroinformatics program. We've just invited him down as visiting professor, and there's 10 million clean patient charts to base all of the AI investigations on. So Mayo's not the only one invested in this. University of California system's deeply into this. Harvard is deeply into it. Northwestern's getting into it. There's a lot of people really investing in AI in healthcare. And some of the solutions for our residents that are stuck with the EHR, and again, so are all of us. Some of it's things like ambient listening technology. So rather than having to type in a note or dictate a note, the note is dictated for you with these ambient listening technologies. We just trialed Suki, where there's another product that I'm going to start trialing next week. These are remarkable devices whereby you walk into the room, you put your phone down, the phone listens to the conversation, gets rid of any extraneous conversation. So if you're talking about, your patient's grandkids or the latest hockey game or whatever, all of that is out, and they put together a nice medical note based on listening to the conversation you did. You then edit and accept, and there you go. Your note is done. This is going to save us a lot of time. This just came out in Nature Medicine a few months ago, using LLMs to summarize clinical text information. We're going to be doing this. We're trialing this at Mayo, Florida, in a couple of months. We're the beta testing site for the surgical programs within the Mayo system, and our program is going to be using these. So any patient with a large chart, whether they were transferred in with a large chart, we're going to be summarizing it for the physicians, or somebody who's been in the hospital for a long time and new physicians are coming on, there's going to be a summary generated via this AI program. This is very exciting. It's going to be a time saver. It's going to be, I think, a satisfier for anybody that interacts with EHR, and frankly, that's everybody. Other ones that we're rolling out through Mayo, Florida, and the Mayo system is summarizing discharge summaries and operative reports. All of this is underway. It turns out that it can be done with every bit as accuracy as a medical expert. So discharge summaries are no longer going to be a burden. It's going to be done in conjunction with AI, and also coding. The coding is difficult for neurosurgeons to keep track of. I'm talking about specifically US-based coding. And our coding system and the payment system in the United States is so ridiculously complicated. It's one of the strongest arguments for universal healthcare in the United States. But AI is going to help us with our coding as well. And then interactions with patients, I have no doubt. In fact, I know it's going to be happening because we're rolling it out at Mayo, Florida. And this is going to be interacting with your patients in your in-basket. So when patients text you with questions, the first iteration of that answer is going to be, at least we're trialing this, is going to be written by an AI. You're going to look it over and then accept, edit, or delete. This came out of JAMA Internal Medicine last year. This was physicians answering questions to patients on an open Reddit forum versus an AI doing the same. The AI was rated by physician experts as 3 times more informative than the physician expert, and also 10 times more likely to be rated as highly empathetic. So these are things that are coming our way. These AI programs are going to be used in our interactions with patients. So I'm not the only one enthused about AI in neurosurgery. You can see that's this exponential graph here of AI-related publications in neurosurgery. Taking a look at AI literature in neurosurgery right now, this is a nice paper put together by Michael Ivan and his team down at University of Miami. Just taking a look at where are the publications coming from. There's a scattering from all over the world, but it tends to be largely of the West, with the United States leading right now, and then the Far East. The institutions doing it, it's Harvard, it's the California system, it's Mayo, it's Northwestern. And this is the evolution of what AI topics are being covered in neurosurgery, just starting initially with surgery, machine learning, and so on. And then it just went into everything. Essentially, all of the subspecialties are now investigating their fields with AI programs. So when you decide I mean, if you're taking a look at an AI related paper, how do you read it? How do you judge it? Well, the answer to that is it's much like any standard program. You take a look at it. I mean, are the questions asked reasonable and answerable? Was the data set complete? Was it clean data? And then, did they answer the question they were looking at? The difficulty really is in interpretability because the inner workings of AI is a bit of a black box. I have a whole different presentation on how AI comes to the answers that it comes to within the black box, and it's all evolving towards neural networks. There's other ways of doing it, like the Monte Carlo the Monte Carlo system that DeepMind used for AlphaZero. Now, there's a lot of different ways it can be done, but it does seem to be evolving towards convoluted neural networks and much larger neural networks over time. And that causes a lot more expense, time, and frankly, energy used in computing. Right now, 10% of the energy used in the world right now is computing energy, and that's growing rapidly. And then in taking a look at AI papers in neurosurgery, when you look at it and you compare it to our tripod compliance that we hold our other statistical models to, AI papers tend to be pretty good with this compliance, with the exception of external validation. Only 15% of the AI papers in the last 5 years published in neurosurgery have any sort of external validation. And again, that makes it difficult to figure out, well, what do you do with this data? I mean, how do you interpret that data? Is it reliable? And in reality, most of the time, when we find something that an AI program figured out, we have to find a way to externally validate it. There are ways to inquire within the AI program itself, but oftentimes it just leads to another study to try to get to a validation of the idea that the AI came up with. In regards to education, because this is an education seminar, and we're talking about things like simulation and ergonomics and so on. So let's talk about education. Education in the old days looked like this. These are all old books that my former partners left me from neurosurgery. This was the way neurosurgeons learned in the past. There was almost no video. This is a picture from the Society of Neurological Surgeons from about 75 years ago. This is how neurosurgeons learned. I mean, there's almost no video. They'd have to go and watch surgeons operate. Nowadays, there's simulation. We do a lot of simulation, and it turns out these simulators are very good. Of course, there's a lot of variability of what's good and what's not so good, but generally speaking, in surgery, simulation works. Of course, some simulators are better than others. These are just a variety of simulation projects that I've been involved in. I was involved in the SNS resident courses for a decade. We did a lot of simulation work through the SNS. The hardest thing, of course, to simulate is going to be communication and professionalism. That's quite a different challenge. But through the SNS courses, there were so many different simulators that we trialed. We did our best to train our residents before they ever touched a patient on a variety of different simulators, whether it's microsurgical or spine-based. These are our early efforts. And then, of course, COVID hit, and then we had to do it all virtually. We did our best virtually, but there's really nothing quite like in-person simulation. We've gotten back to in-person simulation in the SNS courses this year. And in regards to neurosurgical simulators, we are, I'd say, a good decade behind the general surgeons, but we're working on it. This is the SNS AI and Neurosurgery Task Force, and we're specifically looking at education. And education, of course, means simulation in neurosurgery. It's led by Omar Arno at Harvard, and it's been fun working with all these people. Sam Browd is a leader in simulation at University of Washington. There's a digital neurosurgery program that he put on this past year that was excellent. But we're all working on making our simulation AI-based and more sophisticated in neurosurgery. And we're doing a project right now. We finally got clearance to do a project with the ABNS, taking a look. We're our first toe in the water of looking at the ABNS data set is going to be based on coding. And the reason is it's just de-identified data, so there's very little risk of any sort of data leak. But the ABNS POST system, this for those outside the United States, the POST system is neurosurgeons in the United States have to submit the data and the imaging from the first 125 cases in their career to be reviewed by ABNS directors in order to sit for your oral board's examination. So over the last decade in collecting all these cases, there's now 155,000 cases with imaging and follow-up, 90-day follow-up in this system. So it's a very, very rich data set of people early in their career and what they're doing in neurosurgery in the United States. So it's a really, really rich data set for us to take a look at with artificial intelligence. We're starting off with coding. After we prove that it's safe and that there's no data issues, no data leak issues, we'll start looking at the clinical data as well. Like I said, we're about a decade behind the general surgeons in AI training and simulation training, in part because AI requires digitizable, analyzable, unambiguous data. And that really means visual data, it means digital video. So much of what's done in general surgery is done through the laparoscope. So they have these massive data sets of surgeons doing actual surgery, surgeons doing simulated surgery on simulators, and they can compare experts with non-experts, with senior residents, junior residents, medical students, novices, etc. And then they can determine, looking at all of this and then using external validation to figure out who's good and why. What makes a good surgeon? And not too surprisingly, what makes a good surgeon in general surgery is very similar to what makes a good surgeon in neurosurgery. And it has a lot to do with efficiency and flow and bimanual dexterity and the flow of the operation. And then speed is a byproduct of it, but not a primary product of it. This is from JAMA. This is taking a look at, again, just how general surgeons take all of this data, segment the data, track it all the way through an AI program, and then look back once it's externally validated and to say, how can we take a look at our trainees and tell our trainees how to get better in neurosurgery? And so it's just taking the implicit and making it explicit. We can all look at somebody operate and say, this person's really good, but it's hard to explain why. Well, guess what? AI is really good at explaining the why. So here's another paper, AI in general surgery, just taking a look at an AI simulator with trainees going through. The bottom line is it makes them safer, it makes them more efficient. As a byproduct of becoming safer and more efficient, initially it makes them slower, but because they're safe and efficient, they'll eventually get faster. Here's one of the early efforts in neurosurgery here. And they're looking at expert surgeons versus residents versus medical students and just demonstrating the learning curve and demonstrating what we think makes a better surgeon and how long it takes to get somebody trained up. We did some of this in neurosurgery. This is Bernard Bendock's microvascular anastomosis simulator. We did this through the SNS courses for about a half a decade. We collected a lot of data on it, and that data helped us to train trainers to teach things like microsurgery. But it also gives us a backlog of video information that we'll be analyzing, and it's going to allow us to use an AI program looking forward. So the SNS AI task force is going to be looking at anything that's digitizable. So pituitary surgery on video endoscopic third ventriculostomy, anything that is on video is possible. Now, this, of course, is expensive, and there's a ton of data collected. And that's why it has to be centralized, which is why we're doing it through the SNS, because it'd be very expensive for individual programs to try to do this themselves. And now, finally, I'm just going to wrap up because it's 7:30 here on the East Coast with a quote that I find fascinating. John von Neumann was one of the originators of the computer and also of artificial intelligence. And this, for any neuroscientist, this has got to be exciting. When we talk about mathematics, we may be discussing a secondary language built on the primary language of the nervous system. That sort of circular logic for a neuroscientist is absolutely fascinating. But when you look at what the brain is and how it's constructed, and you realize that it's about 100,000 individual units that are their own AI program that all work in conjunction with each other. As a neuroscientist, you can't help but be fascinated with artificial intelligence. Thank you.
Thank you. Thank you very much, Rich. Absolutely fascinating. And, just as you were listing all the possible applications and, you try to imagine where we might be in a few years, just there is no limit. When I look at technology, I'm always, also fascinated by the ability of technology to, in a way, have the potential of democratize healthcare across the globe. Because I think, like to your opinion about this, applications of these newer technologies might be actually, in a way, easier in those places where more traditional ways of delivering care are not so established. I look, for example, at the digitalization of banking. It's really taken off in areas of Africa where there was not a well-developed, more traditional model of banks with the branches, local branches everywhere. And when I think about something like this, it's really, it has a really a great ability to improve healthcare at the global level because it would make it easier to. What's your take on that particular aspect? We have at this point more than 90 participants from all over corners of the globe.
Mm-hmm. I would completely agree with you. I'll just give an example right now. If you have a tough case and you want advice, and let's say you're in a place where you're relatively isolated, there's not a lot of senior neurosurgeons around. Well, you can just go to Atlas GPT and put in the details of your case, and you're going to get a very thorough, cogent response in how, based on neurosurgical literature alone, how you might consider handling that case. That is now instantly available. You've got a second opinion available right now as of 10 days ago. That'll only get better. There'll be more programs that'll come out. There's going to get to a point, in fact, Atlas GPT's planning on it, where you can enter the volumetric data of the MRI scan or MRA scan or whatever you need to do, and that volumetric data would then be analyzed by the program, and it could give you very, very detailed answers about, yeah, you might consider doing this, but be careful because the third nerve is probably pushed up, and watch out for the anterior choroidal, it's sitting on top of the tumor. That's coming. And I'm not talking about in the distant future. This year, that's coming. And then as far as things like you're isolated, you have general neurologist, you don't have an epileptologist. You're going to have an AI program, who's going to be able to interpret that EEG and do it very, very quickly and for very little expense. So all of this is already done. It's coming. As far as dealing with and wrestling with electronic health records, that's all in trial right now. Within a year, it's going to be used through the Mayo system. It's going to be used through other systems that are trialing it, and then it's going to spread everywhere. And I do think it's going to make everyone's life a little easier in navigating the healthcare the way it is, and freeing us up a little bit from these electronic health record overlords.
The other thing is that the profound effects that this has on education. Like if I look at development of imaging and how it changed neurology, for example, in the 50 years ago, you need to be a superb neurologist and knowing all the little signs and come up with the differential. Nowadays, that is, in a way obsolete. You get an MRI and you get your answer right away. So should medical schools compress the curriculum and so much emphasis on differential diagnosis? Probably it's really not going to be, nowadays patients come in very difficult problems to diagnose: CSF hypotension, Cushing disease. The patient, they put their symptoms on Google, they come in and say, doctor, I think I have this disease. How can we make sure that the education, and I've always been obsessed a little bit to try to compress, probably because it took me from 89 to 2000 to 13 years before I could actually be a neurosurgeon on my own, 13 years of postgraduate education. How can we compress, and how can we make sure that our education system is on par with the technology and make those changes without letting the market or the technology eventually forces us to make those changes in a way? How can we be proactive? What's your take on that?
So that's a great question. Both of my daughters are in medical school right now. Both of them went to tech-heavy colleges, engineering colleges, and I insisted that they learn how to code, and they do. I insisted that they learn how to use AI in healthcare, and they do. And there are AI and healthcare elective courses in medical school, and my daughters, of course, did those, and they're going to be they're looking at the future. It's always best to look forward. Don't worry about what happened in the past. You can always study history but right now, look at what's coming. And it's distressing to see one of my daughters just finished boards part 1. It's still so memorization based. It's really kind of embarrassing. A quarter of the test is biochemistry memorization. That is not the future. So that's everyone in America has to take that test. That needs to be changed. I can tell you, as a member of the ABNS, we've gotten away from memorizing factoids on our written boards. In fact, as soon as I sign off here, I'm writing 10 questions for the written boards. And they're not factoids. They're things you have to think about. They're things you have to be that are clinically relevant. We've gone through our entire question data set and gotten rid of anything that's memorization based. So we're better than the boards part 1. The medical schools are behind right now in this. At least the medical schools my daughters are at. But you're right. It's got to be more about not memorizing. It's thinking through. There's a concept in AI called Moravec's paradox. Moravec's paradox is that AI is good at things that humans are bad at, and humans are good at things that AI is bad at. So don't worry about being replaced by AI anytime soon. Okay, maybe 50, 100 years from now we'll be replaced. But for right now, we need AI and AI needs us, because there are certain blind spots that AI programs have that are easily identifiable and horrible blind spots that can lead to bad outcomes in healthcare. So it needs us. We need to change our curriculum to work with AI, because students now, they'll use ChatGPT or Claude or any of the other ones to get answers very quickly. They use it all the time. It's second nature to medical students now. They're already moving past memorization. We need to get the medical students to move with, or the medical schools to move with them.
Thanks. Thank
Dr.
you. Oh, go ahead, Vanessa.
Yeah, Dr. Byrne, many participants are asking about the link to get to the Atlas GPT. Is it atlasmedtech.com?
Yes,
I found one.
it's a product with between Atlas GPT and MedTech. Aaron Cohen-Gadol is if you can take a look at his Neurosurgical Atlas website. It's fabulous. Aaron was again disclosure. He was also a Mayo Clinic resident, but it's really, really good. Take a look at that website. You'll see you can query it for any neurosurgical problem, and it'll give you, I think, a pretty good description of what you might consider doing.
And for the SNS AI task force that you mentioned, are you also using numbers in functional neurosurgery, for example, like the targeting that we have before and after, to see how accurate we can get depending on the symptoms of the patients? So are you also looking into that, or only videos, as you mentioned?
Well, right now, I mean, the SNS AI task force is entirely education based, because the SNS is the Academic Society of America. It's the senior education leaders in America. So it's all education based. There are other interest groups in AI out there, and it tends to be a lot of the same people that are popping up in the WFNS. But we're entirely looking at simulation-based education and querying large neurosurgical databases.
Okay, great. Thank you very much for your talk. I was going to ask how you are using your day-by-day life, and you already mentioned that you are teaching your daughters also to use artificial intelligence.
Well, yeah, I mean, the presentation you saw, a lot of the slides and the way the transitions, all of that was AI based. I use it all the time. In fact, the written boards, the group at NYU is actually writing questions now for our written boards in the United States. And those questions will be rolled out for for neurosurgical residents next year. They're not going to be scored yet, though. We're going to see how they do on AI-based written questions. And it's difficult to write neurosurgical board questions. It's quite a bit harder than you think to write a cogent question that already hasn't been written about before, because we've got a massive data set of questions. Coming up with a new question is not easy. It's simple for an AI program. They can pop these questions out, and they're reasonable questions very quickly. So we are going to be trialing that next year.
Great, thank you.
Thank you very much, Rich. And the next presenter is Dr. Salazar from Ecuador, and he will give us an overview on ergonomics in neurosurgery. Thank you, Byron.
Thank you, Professor. Good morning. Can you let me know if you are watching the screen?
We can see your screen.
Yeah. Well, good morning, dear friends. I would like to thank the WFNS Cerebrovascular Committee and especially to Professor Lancino for his kind invitation to this event. And I would like to share some thoughts about the evolving concepts regarding ergonomics in neurosurgery. Great strides have been made in surgery during the past 4 or 5 decades. So most of them are related to scientific advances and surgical technique itself. So we need to have a philosophy that shows our appreciation and gratitude for the unwavering support, guidance, and lasting impact of our mentors in our careers. So it is important to remind us to become good surgeons. We cannot forget about these important principles like anatomy, ergonomy, technique, the technology, as just we have seen, and of course, our philosophy of our mentors. So the way we learn is decisive in the development of how we teach. So attention to learning and teaching ergonomics, encouraging repetition, study, observation, and combined with the daily practice routine, it is an effective method to reach technical improvement. So we know that residency presents itself with challenges that must be met at each stage of the residency. And of course, neurosurgery differs greatly from other surgical specialties. There are long surgeries with a high level of stress, and surgeons may present work-associated pain. They can present potential hazards for injury and disability, risk of significant musculoskeletal disorders, and a reduced career longevity. So if we can see here, this tennis video, I love tennis, we can see that everybody's playing tennis, but at different levels, and of course, with different techniques and different results. So it is evident that if we do not have an adequate technique, we will not be able to obtain the most satisfactory results. No? And now with the Olympics, to achieve greatness, we have to start from the beginning. That means learning the correct technique of every activity we put our mind into. So to run fast, to go to the Olympics, to shoot, to run, there is always a technique. To play tennis, there is always a technique. And of course, to do neurosurgery, there is a proper technique. So to become a vascular surgeon like Professor Lancino, you need to acquire a different set of skills that are beyond the ones that you get as a general neurosurgeon. You need to get comfortable with microforceps, micro needle holders, working with tenon sutures. So to get there, first you need to master some other techniques, like create strategies for reducing hand tremor. That is important. To be aware of time and speed of the procedure, to choose the wisely and adequate instrument, and of course, think about exposure. So ergonomics is the study of the interaction between humans and their working environment that optimize the user's performance. And for example, if you go right now and Google ergonomics and surgery, you might get this result. The HapoFront is a physical assistant device, this exoskeleton, designed to relieve the upper limbs, shoulder, elbows during repetitive tasks and encouraged to use it in surgery. But for me, this is not the way to solve ergonomics. The solution is not to buy an expensive piece of technology, instead you need to buy and learn the basic principles to use the instruments, to avoid tremor, to have comfortable position during surgery. And as you see here, 2,608 euro, no? So I guess this is not available for everyone in the world, but the most basic principles are. So ergonomics still remains an unknown surgeon. So in this paper, more than 58% of the surgeons that were interviewed had no knowledge about the implications of ergonomics in surgery. So most master surgeons in the first chapters of their books and revisions, they make special remarks about ergonomics in surgery as a fundamental keystone to learn before performing a surgery. So when we talk about ergonomics related to neurosurgical instruments, we have to be clear that the selection of an incorrect grip type will affect the quality and performance of a task. If you hold your instrument with unnecessary force, it increases muscle fatigue. And of course, as the grip type becomes more precise, the grip strength reduces. So if we have to analyze which grip is the best grip type is the pen grip. So it is held by the tips of the thumbs and index finger, and is stabilized by the middle finger. So it provides an inferior stabilization of the instrument and allows a free line of sight. If you use, for example, a lateral pinch, it has no inferior stabilization and your thumb can obstruct the line of sight. We need to avoid the pistol grip because it uses wrist and elbow movements. We prefer bayonet instruments rather than straight ones because it allows us to have a clean line of sight. And the ceramic isolation concentrates less heat and preserves better the tissue. We know that the finger depressions or holes allows a precise manipulation of the instruments, preventing slippage from the hand. And if we compare, for example, the technique using laparoscopic surgery where very, very long instruments are used and needed, the hands are in the air without any type of support, and therefore is more tremor, less precision. And the same happens if we use in neurosurgery very long instruments while we're working on a superficial plane. So shorter distance to the skin demands shorter instruments. And this allows the hand to rest comfortable closest to the craniotomy. And we need, of course, prevent to leave the hand hanging on the air. Regarding bipolars, it is important not to close the tip totally, coagulate for 1 and 2 seconds at a time with an intermittent open-close movement, and avoid maintaining long intervals in a single spot because the tips may stick together. Okay. Also, with the bipolars, never clean the tips of the bipolars with a scalpel blade because it damages the insulation or the coating. So, regarding the instruments, the weight and size of the instrument should be proportionally distributed. The weight should not cause fatigue. The size of the instrument should be appropriate for 90% of the surgeons, whether they are male, females, right-handed, left-handed, and we prefer the made surfaces to avoid visual fatigue. So when we talk about the sucker, it is also important to grab it with a pencil grip to avoid using the pistol grip as we just said. And if the suction is not properly arranged, like in this case, it will move into your surgical field, blocking the view. So we have to avoid this setup and set up the hose, properly so it can rise and falls down following the contour of your hand. And what about the dissectors? No, the dissectors should not be held too far or too close to the tip. We know that if you are too close, our hand will hide. Like in this case, will hide the tip of the dissector. And if we cannot see the tip of the instrument, we shouldn't do any movement. We have to use the convex part of the dissector over nerves, vessels, and aneurysm's neck. And all movements are performed only with the fingers, with precise, with delicate and deliberate movements. What about micro scissors? The sharp dissection is the safest method for dissection, especially under high magnification. So the tip of the micro scissor must always be into view. And if we cannot see the tip of the scissors, blind sharp dissection leads to catastrophic complications. So if we do not see the tip, we cannot cut. Here we see some kind of mistake, cutting without any support of the hand or arm with an instrument that is too long, while in a superficial plane. And we have to cut only with the tip of the scissors, like in this case. And we have to pay a lot of attention to the opening and closure of the instrument. Neurosurgery is a two-handed technique. So you need a firm pulse, delicate movements, and above all, to have the control of the tip of your instruments and gentle management of neural structures. We have some kind of other instruments that are for more aggressive techniques, like these bone rangers. So it is heavier than the other instruments and must be taken, in that case, with 2 hands. It must bite the tissue, like we see here, like biting the epithelium out, and not tearing the tissue like we see here. It's tearing the interspinous ligament, or like this demonstration, tearing the catheter. And of course, with the Kerrison ranger, we see here on the left the correct technique, holding the instruments with both hands, making a biting movement, while on the right side, the inappropriate technique, holding the instrument with just 1 hand and of course, tearing the tissue with these rotational movements. In order to avoid carpal tunnel syndrome, people are using these pneumatic Harrison wrenchers. So it has been said that it helps alleviate the manual fatigue, the soreness, maybe to reduce the occupational injuries, minimize surgeon's fatigue and effort. However, it is important that you can lose the feeling of the tissue that you are about to cut. Regarding the scrub nurse and delivering the instruments, if the instruments are delivered, like in this case, the bayonet upwards, the bayonet downwards and open, it is impossible to handle, and the surgeon has to rearrange it, which means that removing his vision from the surgical field. So that is why instruments must always be delivered with the bayonet upwards and closed. There are some strategies to reduce hand tremor. Hand tremor has been described as the enemy of neurosurgery. And we have this technique, the finger placement technique. So these fingers form a unit. The hypotenar eminence is placed at the margin of the craniotomy to reduce the tremor, and the hand rests on the ulnar side of the arm, and we use short instruments, like in this case. Of course, we have to avoid keeping the hands on the arm because the lack of support affects the hand stability. We have this another technique that is called the quiet hand technique. So the main movement is done by the thumb, combining flexion and extension movements only of the thumb. We have this forward hand technique. So this technique uses a device, which is this one. It's called the bell and bridge, that is placed at the edge of the craniotomy, and it gives support to the first 3 fingers. So this technique has been shown to decrease the tremor in 30%, especially in vertical movements. Another way to reduce tremor is the armrest. And of course, in this paper, they compare some techniques, and the best results were seen by using the armrest and the finger placing technique with a little bit of flexion of the hands above the surgical field. Another strategy to reduce the tremor is to use the non-dominant hand to stabilize the instrument. So, for example, in this case, controlling the depth of entry of the endoscope. With some ergonomics and other devices that are most important in our daily practice, like the microscope. So the microscope needs to be properly set up before surgery. It means that modern microscopes are balanced with a push of a button. We know, but these old ones, you need to know how to balance them and to make them function properly. And let us remember that in third world countries, it is sometimes the best we have could be one of these microscopes. The microscope must have freedom of movement regardless its position. That means the connection cables must not limit any movement of the microscope. When focusing, normal light sight surgeons must adjust the eyepieces to 0. And if you have more than 3 diopters, you can use your glasses. So the interpupillary distance must be adjusted in each case for each individual and provides this advantage of stereoscopic vision. What about the handle? When the handle is rotated 15 to 20 degrees, the wrist is in a neutral position and reduces fatigue. But when the handle is in a vertical position, the wrist is forced into an ulnar deviation, and you can have a risk of tenosynovitis. When draping the microscope, when you drape the microscope, we should drape it and leave it, and to avoid and leave it too loose, because you can hit the surgeon's head, obstructs the view, gets contaminated. If we are draping it, for example, too tight, like in this case, it does not allow to move as freely as you need it. We have to avoid draping the microscope with drapes, with lobes, with improvised things. And the best option, of course, is to draping with these air vacuum systems, but we know the costs are the highest. For example, this was taken the other day, and we see here, for example, that in a poor planification setting of the location of the microscope before the surgery, it complicates its moving around the OR and putting in danger. For example, in this case, there were some spine procedure. They collocate the ID over here. So they wanted to change the microscope position, and they couldn't disconnect the ID. So they they ask the nurse to come here to climb over the table. So you can see here in what danger she might have been. She tried to leave the power cable, above the microscope, so it has the risk of contamination. So this is unacceptable. This cannot happen if you have a proper planification. What about the ergonomic position of the surgeon? We know that several reports indicate affection of the cervical spine, the back and shoulder level. And in any case, we have to avoid hyperextension, since it produces greater stress, tension, and pain in the cervical region. And as we want to work in a neutral head position while working with the microscope. Of course, we can see here some examples of an incorrect posture where the line of sight, as you see here, goes from inferior to superior when we want to achieve a neutral position, a neutral line of sight with a microscope. What about endoscopic techniques? We use endoscopic techniques where in the spine, skull base, and if the screens are, like in this case, too high, once again, you have a cephalic hypertension, and the vision is from inferior to superior. So the ideal is that the endoscope towers and screens should be at the eye level, 15 to 30 degrees down. And we have to also avoid placing the screens too far from the surgeon, like in this case, because we lose focus, and depending on the size of the screen, small anatomic structures. So the ideal screen should be placed 1.5 meters in front of the surgeon. And these modern techniques like the exoscope, we know that the exoscope appears to be a safe and effective alternative to the operating microscope. But I think that the ergonomics of this device will also depend on the model of the exoscope. Like we see here, here's the setting of the monitor, that is in front of the device, so you cannot see, you have to stand up. So it's ergonomic, also a problem. So the location of the screen, it depends on various factors, how much you turn your head, like in this case, to good look of the screen. If you only use one monitor, the assistant, of course, is off focus, and the surgery becomes a 2-hand surgery instead of a 4-hand surgery. So you have a lot of devices, a lot of new innovations, so we will have to see in the future how it goes regarding ergonomics. In this case, for example, you have to avoid hyperflexion of the head. So in these cases, we see how there is a cervical hyperflexion due to a bad posture of the surgeon, and in this case, in spinal surgeries, the hyperflexion occurs because the surgical table is very low, or maybe the weight of the magnifying glasses, like in this case, are increased. In this case, for example, the microscope eyepieces, they do not change position, and the surgeon has to modify his posture to be able to see. So this increases the flexion of the neck, increases fatigue, increases neck pain. We have to avoid unintentional contamination by flexing the head so much that the cables of the equipment, of the instruments, come closer to the mask and gets contaminated, since the mask is not a sterile one. Or in this case, for example, when the non-surgical cap contaminates the sterile sleeve that covers the ID. The gauze cannot expose part of the non-sterile scrub because of risk of contamination. Therefore, we need to try to cover it or to get a wider gauze. Regarding spine surgery, when flexed, with the additional weight of the lead vest, the sagittal balance changes and there is a greater stress in the lumbar region. So we know that the vest can weigh up to 6 kilos, so it is a lot. And the ideal position is to maintain a relaxed posture to avoid cervical hyperflexion and raise the table higher. We need to avoid the boot welder position that can produce functional scoliosis, widely seen in surgeons that operate standing. Regarding the standing position, we know we have to avoid standing and resting only on one leg because it increases the entire body load of that leg, produces muscle fatigue, creates body instability, avoids using the pedals, and of course, avoiding the hyperflexion of the trunk. And if we compare once again with the usual surgical position as a general surgeon and neurosurgery, they are very different. So in general surgery, the surgical table is adjusted in relation to the tallest person of the team. And many times the main surgeon stands on racks, like in this case, and maybe more uncomfortable. So the placements of the monitors, like in this case, should not cause a discomfort to the surgeon or produce awkward positions like we see here. So many times the elbows are far from the body and shoulders very low. So in neurosurgery, the most comfortable person should be the main surgeon, seated with the arms, hand, wrist, and supports, the elbows close to the body, and movements are performed only with the tip of the fingers. So the sitting position has its advantages. We need to have our knees angled, our feet on the ground, to use comfortable padded seats with adjustable height, and it is important to wear long gauze to avoid any risk of contamination. When we compare the sitting versus the standing position, it is recommended to sit down during the intradural portion of the operation. So in these pictures, we can appreciate that the standing position may lead to arm fatigue, hand fatigue, producing more tremor, less precision. And what about the position of the assistant of the co-surgeon? Nobody talks about this, because by focusing on the correct position of the surgeon, we forget about the position of the assistants, and many times they have to adapt to uncomfortable positions for the surgery. So if they manage to sit down, the chair is too low, too high, the feet cannot touch the floor. If the co-surgeon is on the other side of the craniotomy, like in this side, she's not going to see the surgical field, and she cannot help properly. If, for example, it is common that the assistant is standing while the main surgeon is operating comfortably in the operating table. So we need to try to avoid uncomfortable positions. Regarding the semi-sitting position and surgeon's comfort, it can cause, the surgeon's fatigue in the shoulder, arms, hands, even though they have an armrest, because working with the outstretched arms really is exhausting. So in this case, Professor Roberto Leal from Brazil, he's adapted this lateral semi-sitting position for vestibular schwannomas, in which improves not only the surgeon's comfort, but also the patient's. We can have these target stretching micro breaks every 2 minutes, 2 minutes every 20 or 40 minutes. That depends on where we are in the surgery and we have time to do it. But it's a way to relax a little bit, so reduces the pain in the neck, shoulder, and lumbar region with these exercises. There is a lot of said regarding the left-handed in neurosurgery. So in this study, several etiologies are mentioned to analyze the performance of a left-handed neurosurgeon. So 17% of these neurosurgeons were left-handed, and these lefties had a higher degree of ambidexterity and a lack of surgical instruments for left-handers, and the absence of surgical training for left-handers was reported. And what they saw at the end was that these challenges tend to diminish in time, that they had better results in training for left-handers while they have mentorship of left-handed people. And, we have seen these professors here that we have, that they are excellent, they are left-handed, and there are no excuses to become a master left-handed surgeon, even though all their mentors were right-handed. So we have to train a lot, we have to keep being active. Some words about pregnancy and surgery. We have to consider compression socks, reducing the number of surgeries, especially in the third trimester, to avoid heavy shifts, to hydrate, to take breaks, to sit down when possible, and use maternity belts. Professor Spetzler already published that there are some internal and external factors that can influence the surgical performance. So in neurosurgery, we know there is a high level of mechanical exposure due to the use of drills, to blades, to sharp objects. So it is recommended to use 2 gloves, one for craniotomy, 2 gloves for craniotomy, and 1 glove during the microsurgery of the intradural part of the procedure, and change gloves every 90 minutes because of increased risk of microperforations. You have to keep always your eyes on the surgical field. You don't have to try to look for the pedals, or any distractions. It says something about mats and pads on the floor. Are they really dangerous? I know that floor-based fluid management mats and pads are more effective and economical option than throwing blanket, towels, or sheets down the floor and to try to absorb the fluid runoff. So we have to ask ourselves, how does the mat feel under the surgeon's feet? How does it impact their posture and balance, especially during long cases? And we should think on the properties of the pads. Are they disposable, reusable? Do they suck or absorb the fluids? And remember that if we use drapes without any fixation to the floor, they can move and represent a risk of falling down to the surgeon. This is well interpreted by my co-surgeon. And here we see different types of maps and pads. There are different prices also. Some considerations regarding the patient's transfers it is important always to have an adequate number of people to the transfer. The destination surface should always be lower. To take breaks, that means one transfer every 30 minutes, and use some different devices like friction reducing sheets, slider boards, or in some cases for heavy people, these air assisted devices. Some considerations regarding patients' ergonomics. We have to avoid using the gel pad directly over the skin because the risk of pressure burns, and always protect the skin with undercast padding and drapes. Here we can see in this case that I didn't protect this area of the thorax and the patient got a pressure burn. So I learned from that. So now my recommendation is to use as many pads to protect the skin when the patient is in prone position, especially protect the torso, the abdomen, all pressure points, protect the face, not to avoid eye compression and the risk of blindness. Some external factors, we know alcohol consumption, don't drink and operate. Well, it's perfectly clear. The duration of the procedure, we know that there is a 25% increase in tremor at 3 hours and a 50% increase in tremor at 6 hours of surgery. Fasting produces or increases the physiologic tremor. And we know that we have to train. We have to train. Especially we want to have large volume of cases, training methods like suturing gloves, elastic tubes, animal models. Laboratory training is mandatory. Simulation models, as we just seen, it is important to get the feeling. Live operation workshops, operative videos, visiting other departments, stay alive, stay active, and a self-directed learning. And we have to avoid increase the administrative work. So it is important to participate in congresses and updating courses, to be able to listen to the experts in the different areas. And vocation. Having vocation does not only mean transmitting the knowledge of teaching, how to build it with enthusiasm, commitment, confidence. And of course, nobody knows that to do it like the parents. So we can see here in this picture, Professor Amef, Professor Evandro, Professor Borba on their knees on the floor, showing their philosophy, and that shows vocation. So as my final conclusions, I guess we need a cultural change, because we need to get our hospital leaders to understand that pain affects not just productivity, but surgeons, but it also has a detrimental effect on their quality of life, their ability to teach, their well-being, and the quality of life they care and they provide. So I'm glad to say that the next step regarding ergonomics education has been able to be, I have been able to work not only with neurosurgeons, but with ophthalmologists and general surgeons, organizing some lectures and hands-on courses. And the results have been very promising. I thank you once again, Professor Lancina, for this invitation. I thank you all.
Thank you so much, Dr. Byron Salazar, for this great talk. As Dr. Evandro always used to say, it's the ergonomics, it's something that we have to keep learning and to keep evolving. He used to look back all his surgeries and try to see how he could improve for the next one. And something that he always was teaching us was to always get the wrist, to get a good rest for your wrist, so you have less tremor. And actually, he was a surgeon that I saw that had less tremor or very precise movements during surgery, as you probably all saw his videos and even in person. So, and then based on that, what we are doing, what you changed in your practice when you go back and look in your surgeries, even nowadays, because I think that this is something that we have to keep evolving. So what you changed lately, you mentioned about one of your patients that now you're protecting more, but in your practice, in your day-by-day life, what did you change lately?
Thank you so much, Vanessa. I guess it changed a lot when you come out of the residency and start to to be your own surgeon, and during our residency, the preferred way to do the cases was of my chief of department was to do it in a standing position. He liked to be standing up, and he was excellent. He had a lot of success, and maybe it was the way he learned it, maybe. And of course, if my boss was standing up, I of course had to be standing up with him. No, I wouldn't sit down. And I mean, that's maybe the thing I changed the most. When I finished the residency program, I start to look, to other professionals. I have the honor to operate with my dad. He's also a neurosurgeon, so he had some different techniques. He always was sitting down, so it was nice to see and compare the different techniques. And for my personal experience, as I have seen many people, I prefer to sit down right now. I guess you can stay and pass more hours in the OR without getting tired, without getting any cramps in the legs. So maybe that's what I guess I changed the most. The position in which nowadays I prefer to sit down in any kind of surgery. So for spine surgery, it's a mess, because there is no way, I haven't found yet the way to operate a spine procedure, sitting down. And, there's always a lot of pain. And we know that technology is every time it's getting better. And for example, these Iron Mite-like suits, that are promoting now to help surgeons to reduce lumbar, cervical, or maybe shoulder pain, are expensive, and they are taking this promotion to try to sell this, instead of actually going back to these principles of ergonomics, that it can be applied in any type of surgery, in any field, and it doesn't cost anything. No?
Yeah, great. Dr. Richard Barr?
Yeah, so first off, this is an underappreciated, very important topic, and that was an excellent presentation. A couple of comments. The first thing is, I was one of the authors on that left-handed paper, and full disclosure again, I'm a left-handed surgeon, which is why I found it interesting. It was almost twice the number of expected number of left-handers in neurosurgery as compared to the general population. I don't know why, but I can tell you that it's very difficult to be a left-handed general surgeon, because all of those operations are handed. In other words, the gallbladder is up in the right upper quadrant, so every operation is set up for a right-handed person to get the right upper quadrant. The spleen's in the left upper quadrant. The brain is symmetric. The spinal cord is symmetric. The spine is symmetric. So maybe that's what attracts neurosurgeons, left-handed neurosurgeons, because it doesn't matter what hand you are. Lefties have some advantage in that they're a little bit more naturally ambidextrous, because they grew up in a right-hander's world. The buttons on your shirt are set up for right-handers. The door set up for right-handers. Your computer set up for right-handers. So lefties always they're good with their non-dominant hand, because they had to be. I think I'm amazed at how many neurosurgeons will do complex microsurgery standing up with no hand rest. And there's some really good surgeons that do that, but I guarantee you they'd be better if they do what you're talking about. If for a complex microsurgery, to sit down, rest your hands, do the operation with your fingertips, eliminate the arms, elbows, shoulders, etc. And when you think about sitting versus standing, I mean, just watch any concert pianist. How many concert pianists have you seen standing? It doesn't exist. If you want to be accurate with your fingers, you need to eliminate all the other joints, and you're going to get better. You might be great as you are, but you'll be better if you do the things that you were talking about today. I guess my question for you is how many, I would love to know what percent of neurosurgeons, when they're doing complex microsurgery, are standing versus sitting, using a mouse switch or a foot pedal versus having to put everything down and move the microscope. I mean, in a big acoustic, you'll save 2 hours in the case if you use a mouse switch or a foot pedal. Do you have any idea? Is there any sort of survey that Zeiss or any other company has done to see how often people are using their mouse switch or their foot pedal? Is that known?
Thank you, Professor Byrne. Actually, what I have investigated, to learn while researching for this topic was, for example, that there is a curve of a learning curve to use the mouthpiece. So it's not as simple as it sounds. Actually, it needs to be taught. It needs to have some feeling about it. And many surgeons, actually, they do not adapt to the mouthpiece. They start to salivate too much. And maybe in the COVID time, with the mask, with the rigid masks, the KN95, I guess there were, the mouthpiece couldn't enter, through the masks. And, I guess it's still, a few percentage doesn't like the mouthpiece. So they prefer to have, for example, the surgeon or the co-surgeon, the assistant, to handle maybe some of the buttons, the focus. They use sometimes the pedal, as you said, but I guess it's still a developing issue that should be, as you said, investigated, some research. I guess it also depends on the ability you have to buy the whole microscope. Maybe what happens here in Latin America, you get a budget that is so fixed that maybe you can buy just the microscope. You don't have money to buy these complements. So I guess it depends of the people, it depends on the person. But of course, with this new technology, the exoscope now, there is a debate. No, actually, if the exoscope has better ergonomics than, for example, the microscope. I still don't know. I guess it depends on the model. I just said I have used some exoscope types, so maybe ones are maybe more friendly than others. But the day I see Professor Lancino use an exoscope to take an AVM out, maybe I will convince that it is better. But in the meantime, I'll stick with the microscope.
Great. Thank you so much, Dr. Salazar. Thank you for the great talk, and very important. Many people here in the chat are thanking you and thank you for all the advice that are very important. So let's move on. And I would like to introduce, it's our great honor to introduce Dr. Carlo Bortolotti. Dr. Carlo Bortolotti is a vascular neurosurgeon from Bologna, Italy. He's the head of vascular section of Italian Society of Neurosurgery, head of neurovascular unity, the Department of Neurosurgery at the Institute of Neurological Science in Bologna. So thank you so much, Dr. Bortolotti, for being here with us.
Good morning to everyone. Did you see my screen?
Yes, we can see.
First of all, let me thank Professor Lancino and the Cerebrovascular Committee of the WFNS for the kind invitation. So before to start, the first question is, training in vascular neurosurgery is still necessary for a young neurosurgeon today? So I think my answer is yes, like highlighted by this paper coming from Michael Lawton in this editorial, because in a high volume neurovascular center, this kind of cerebrovascular lesion are absolutely not so rare. So I think that vascular neurosurgeon must be able to deal with this kind of complex giant cerebral aneurysm, partially thrombosed or previous coiled, all in case of high-grade cerebral AVM. So we need to improve our skill in cerebrovascular surgery. And if the number of the cerebral aneurysm treated by clipping is decreasing in the last year, like showed by in this paper coming from the BNI group, the number of AVM or cavernous malformation and bypass cases is increasing in the last years. And we have to rethinking also in terms of cerebral bypass surgery. There is an ongoing evolution in the indication, clinical application in the procedure, and also there are a lot of new kind of bypass like intracranial side-to-side bypass, fourth generation bypass. And also the literature, like showed in this paper coming from Zurich group, has demonstrated an increased number of paper on the bypass cases. So the question is how vascular training can be improved today. We can improve in 3 points with a new approach in the microsurgical and neurovascular anatomy teaching, with the hands-on neurovascular microsurgical course, with using of hybrid simulation model in vascular neurosurgery. So one very interesting new way for microsurgical anatomy teaching is the photogrammetry. Photogrammetry consists in a procedure of a process of surface scanning that utilizes a standard photographic, 2D photographic equipment in order to generate a volumetric video. So let me thanks together with Professor De Notaris, Professor Lanzino, and Professor Maris Periscelda for accepting our resident Amedeo Piazza, who developed, improved, and up-to-dated the photogrammetry at the surgical anatomy lab at the Mayo Clinic. And let me show you one example of the importance of photogrammetry in the teaching of vascular neurosurgery to the young neurosurgeon. This is MCA bifurcation. Like you know, the M1 segment of middle cerebral artery has a vertical course in the Sylvian fissure. And one of the problems for the young neurosurgeon who deal with, for example, SIH cases with a swollen brain in MCA aneurysm is the dissection of the last part of the M1 that sometimes is covered like a blind spot from a large aneurysm. And in this photogrammetry video, can appreciate this problem in terms of topographic anatomy. You can see here left side bifurcation of MCA artery, and this could be a real life for a MCA bifurcation aneurysm. You can see the last part of M1 is a blind spot. It's very difficult to dissect until this part. And in an SIH patient with a swollen brain, it would be very difficult to proceed with the proximal to distal dissection. And in these cases, could be very useful when you control part of M1 to shift to proximal to distal proximal, because the last part of M1 is really covered by an aneurysm in some kind of large aneurysm, and the vertical course of M1 would be very difficult to dissect in the entire length because the last part is covered by bifurcation. And so a beautiful example of utility and of the photogrammetry. It's a different example of photogrammetry for a head and neck anatomy, or for a polygon of Willis, or in these cases of the bifurcation of MCA aneurysm. All these specimens are made in the Mayo Clinic laboratory by Amedeo Piazzi. Another very great example in terms of simulation is the Upsurgeon. Upsurgeon is a high-tech Italian company specialized in advanced simulation hybrid technologies. And they offer different kind of mixed reality simulation for microsurgical training in terms of bypass and anastomosis and microsuture, but also for the clipping of cerebral aneurysm. This in 2024, Upsurgeon has been selected for the pre-meeting WNS at the hands-on course. So I think it's a very great example of simulation, and all this kind of simulation are very easy to use, safe, elegant, I think very useful for a young neurosurgeon. And another very important and very known example of simulation in vascular neurosurgery is represented by placenta model. This is a second neurovascular microsurgical course organized by Italian group of Novara, Dottoressa Grobello, Dottor Del Mastro, Dottor Cossani, with this beautiful specimen of placenta injected, and with the possibility of a dissection of the Sylvian fissure-like, because with the suction tip and microschisure, we can perform a micro dissection of the blue vein from the underlying tissue deep to the bottom of the placenta, simulating a Sylvian fissure, and also facing with aneurysm created in the placenta model with the possibility of temporary clipping, multiple clipping of the aneurysm in the placenta injected model. We organize with Italian Society a lot of international courses like EANS Bootcamp, held in Milano, organized by Professor Marco Cenzato and Simone Peschillo. This is the first edition with Professor Bervini. The second edition this year with a national, international faculties. And another very interesting meeting has been organized this year with the Italian Society and EANS, European Society of Neurosurgical Society, in Milano, so-called Milan Theory course, where a placenta model and also a simulator of endovascular technique. You can see Professor Marco Cenzato, president of the vascular section of the EANS, and with obviously placenta model and live cases. Another interesting meeting we organized with Professor Peschillo is European Vascular and Endovascular Neurosurgery Master Study Program, endorsed by WFNS and Italian Society of Neurosurgery, with the placenta model, a absorption model, with a national, international faculty also in these cases. Last but not least, obviously, the great example of simulation lab of Zurich, the Zurich Microsurgical Lab, organized and directed by Professor Esposito and Professor Regli, where it's possible to face with a perfused synthetic model, perfused placenta, virtual reality, augmented reality, and clipping model with incredible placenta injectable model. But one of the, from my point of view, most interesting example of simulation is the so-called Berna simulation. This is the second Berna simulation workshop for intracranial aneurysm microsurgery, organized by Professor Rabe and Professor Bervini with the international faculty. It's been a great honor to be part of this international faculty with Professor Daniel Walsh from UK. What about the very interesting simulation model? It's a 3D printing simulation model plugged into the screen and perfused. Obviously, you can use esoscope and microscope to deal with this kind of model. Every box is represented by a 3D printing aneurysm, which correspond to the real cases of cerebral aneurysm and perfused with this kind of blood canister. So this is an example of the MCA large cerebral aneurysm perfused, plug into the video. In the monitor, you can consult a book, interesting, like in this case, it's a 7 aneurysm of Michael Lawton. You can, with a touch screen, rotate the angiography of the case, like this is an example of the aneurysm on the digital angiography and 3D angiography. You can take a look to the angiography. Face with that perfused aneurysm. You can see directly. Okay, and the dissection of the aneurysm is a dissection, and the section with the master we can analyze this one. Go ahead. In case of different like this fenestrated or straight staked technique for a large cerebral aneurysm, and with the fenestrated by different Obviously, in the monitor, you can improve the pressure and switch to a difficult situation of ruptured, intraoperative ruptured of the cerebral.
And then the fenestration.
Here,
Of course, you got to get the blades around the forward.
you can see the sequence to face intraoperative rupture with the fear and the concern of real situation ruptured in the intraoperative section.
No.
And I think this is very useful model of simulation because you can face with a ruptured and unruptured lesion. Obviously, it's possible also to organize a remote training with this kind of simulator. Mondino De Liuzzi was an Italian physician who lived and working in Bologna. I spent all my medical school training in Bologna. And Mondino De Liuzzi is very famous because he reintroduced the practice of public dissection in human cadaver and writing the first modern anatomical text. So in Bologna, first in Italy, we are working on this kind of new technology of reventilation, revascularization of the human head. And so we are organizing the first Mondino De Liuzzi microvascular stimulation course in Bologna in March 2025, putting together photogrammetry, the new simulation, the modern simulation in vascular neurosurgery, and this kind of perfused human cadaver. And now we are working on the application of the perfusion on the, obviously, brain vascularization. But the vascular neurosurgery is not important only to the vascular lesion. I think that if you are a young neurosurgeon want to face with a complex skull-based surgeon, he has to acquire also a microvascular neurosurgical technique, because if you want to face with this kind of tumor and by dissect the tumor from the vessel and by sparing siphon and middle cerebral artery, I think it's very important that the young neurosurgeon acquire all the microsurgical neurovascular technique. So thank you very much for your attention.
Thank you. It's amazing how far simulation has gone in neurosurgery. Endovascular simulation really has been very close to real life experience for a few years now, but also open surgical models have now reached the point where I think that this should be incorporated into the training, every training program. When asked about the future of microneurosurgery, and I always marvel at really the improvements we have made in training. When I think about the way we had to do it, if you wanted to learn anatomy, there were really only a few places where you had to go. Cadaveric heads were not available in many countries. I started my training in Italy, and at that time it was forbidden by law. And nowadays, really, you have Professor wrote on lectures at your fingertips. And the same thing is that if you wanted to watch a master surgeon, it was a big enterprise. You had to arrange to go there for a couple of weeks, and if you were lucky, come back and have seen 5 to 7 operations. Nowadays, everything is available on video. So there is no question that the resources available today and webinars like the one we have had today are widely available. So really, the future is bright, and I wish I could go back and do it again with all the resources that are available. Vanessa, I think we've had a great and very productive morning with more than 100 participants at one point, incredible speakers. I leave the stage to my co-moderator for a few final remarks.
Yeah, it was a great morning. A lot of. I just have one question to Dr. Bortolotti about this last model that you showed. That you have the 3D printing and it's perfused. Is it a placenta that is there, or is what's the material inside this 3D printing, and is it commercial available, or is something that we can only find in the courses?
So we are talking about the Berna simulation
Yes.
model. Yeah, the company is called Surgeon Lab, and has been created by Professor Brevini and a PhD coming from Berna University in Berna. So it's possible to buy and also to have for a meeting. So there are different possibility to have this kind of you can buy one or more also, because every box represents different real cases, and so are available also if you want to buy, if you want to use only for 2 or 3 days for a meeting. The name of the company, Lab Surgeon. Surgeon Lab.
Okay.
And the material is 3D printing. It's
3D printing, yeah, absolutely.
3D printing with
3D printing.
different materials, simulating aneurysms and brain.
Yeah,
and,
absolutely.
And it's perfused so that you can.
Yeah, it's possible to increase the pressure by modifying the pressure in the monitor. So you can rupture the aneurysm with 200, for example, or 180. And you can fit with a ruptured aneurysm, you can reduce the pressure, and so the participant can face with a ruptured and a ruptured situation. I think it's very useful and unique example in this kind of problem. And that's the great of this model, I think.
Yeah, very good. Thank you so much for sharing all your knowledge and the way that we can learn more. As Dr. Lanzino said, it's very exciting what the new generation and even all neurosurgeons have available today to keep evolving in the field. So thank you so much, Dr. Lanzino. Thank you so much for all the great the great speakers that we had this morning, and all the participants coming from all over the world. We have many people, even Dr. Jorge Salazar, saying that it was a great section. And so one question here, Trung Dong is asking, how much does it cost? I don't know if you know, but an idea,
it depends. Yeah, no. Now the company started to sell 2 years ago. It depends how many boxes you want to buy, and is variable the price of this this model. Yeah, I'm not able to tell now what the cost of one of this model. Yeah, is a little bit expensive. It's not so cheap. This what I know. Yeah.
Okay, thank you. Thank you so much, Dr. Lanzino. Thank you, everyone.
Thank you, everybody, and great thanks to Himadullah that, as usual, has assisted us in making this technically perfect with no issues whatsoever. Thank you, everybody. Have a great day. Thanks, Vanessa.
Thank you so much, Professor.
Bye-bye.
Thank you, Vanessa. Thank you.
Thank you, Vanessa.
Bye-bye. Thank you.
Thank you, Professor.